Good evening, sir. I'd like to thank Dr. Mithun and Dr. Armugam, sir, for giving me this opportunity. Today, I'm going to speak about a 71-year-old female, a known case of hypertensive and type 2 DM with CAD. So she was ambulant, but limited to walking, using a walker support for the past 2 years. So when she presented with pain and inability to weight bear in her right lower limb while attempting to get up from a sitting position the previous night. No history of fever or weight loss. She had an externally rotated limb. She had previous scars over the posterolateral aspect of the hip as well as the lateral aspect of the middle third of the thigh, and a very, very obvious varus angulation of the knee. So I just go through her previous surgical history. So when she presented to us, it was in 2018 in Feb, where she had already been operated for her left-sided fracture of the neck with the cemented bipolar, and she presented with the right neck of femur, for which we had done an uncemented bipolar. Following which she was doing well. She presented 1 year later with complaints of knee pain, and she had both knees which were paining. And so we had planned for like a stage procedure because we didn't want to put her through a lot due to the CAD. And after 2019, we know that COVID happened and we had lost her through follow-up. And then in Feb of 2022, she presented like this in the ER, and she had presented with a fracture below the distal aspect of the stem. So we also screened for the knee on the right side, which was still bad because we hadn't operated on it yet. So she had a Vancouver type C fracture. So the most important thing was to achieve stability, and the choice of implant as well as the reduction method was something that we had to look for. So the problem was not to get the distal stability at all, but the problem was to achieve stability proximally. So we had used cables, we had used a uni-lock screw. We were also thinking of a variable ankle locking plate to the implant, but thankfully we were able to achieve good stability, and she was weight bearing fine. And then she had presented like 6 months or 7 months ago to the ER with complaints of pain, and that was the initial history I put up. And now she presented with this X-ray. So she had a Peri implant, distal femur shaft fracture, along with an arthritic knee. And so so we had diagnosed it as a complex case and a rare presentation of a peri-implant fracture post a Vancouver type C fixation. So these are the challenges, and I wish to know from the experts on how to tackle this, if it was the same for you all.
I think I would treat the arthritis later. I would address this fracture first. Put a long plate till the end of the femur, remove the current implant and fix it with a long plate and leave it long plate till where you already have it. Approximately and distally till distal femur locking plate, a really long one that bypasses the edge of the stem. That is what I would do. Yeah.
Before that, Tarun, the plate initially must have gone to the distal femur. That's one of the rules of a type C fracture. Because it was it was not a lot of pathological, it's not a traumatic injury. They already have a prosthesis, they have osteoporosis and all that, and you're just asking for another fracture if you do this. Actually,
yeah. So that was the issue as well. So because we were also thinking in mind of the arthritis, and we didn't know how to tackle it at that time, and then now it presented like this.
Do you have an X-ray of the knee by itself?
Right now, sir.
No, somewhere in. Oh, okay.
Yeah, this is the X-ray of right now. So she was not able to weight bear mainly due to this as well. So even at presentation, the only complaint she always had during her visits was the knee pain. And it was like even when she had the neck of femur fracture, she was again and again complaining only about the knee pain.
Yeah, I would do a knee replacement, the long stem through the fracture. Then I would additionally add a plate that goes all the way up to the femoral stem where you are there. That's what I would do.
Okay, sir.
Not remove the last 3 screws and put a rod
Yes, sir.
right up till the and leave the plate.
Okay.
No, Vijay. If you leave the just
No,
remove
but
the
you
last
need to
screws.
just a stem alone may not be sufficient to stabilize this fracture. You need to put a plate again. So you certainly need to put just a stem alone would not be enough. So I need to put a plate again. So I'll decide whether I put another plate and leave this plate, or depending on the local circumstance, or put one long plate all the way up.
Okay. Ajit, sir?
Yeah, I'm inclined to sort of follow what Vijay was saying, except that I'll leave the plate in, and because you got 2.5 widths of the femoral going up, right up till the 1, 2, the bottom 3 screws you could remove.
Yes, sir.
And if you get the rod going right up till as close to the 1, 2, the 4th screw from the bottom.
Yes, sir.
I think, and it's a transverse fracture pattern, so it's quite stable to axial load. It just functions like a intramedullary nail.
True.
That would be my option.
So
Yeah, but I'll do a knee.
Definitely the same thought process was there over here as well. So except for the initial thought process of putting a long distal femur plate when the type C occurred. Other than that, once she presented over here, even we were thinking of how to tackle this fracture site. At the same time, thinking of an intramedullary implant, but how much stability is going to give? Should we add an adjunct plate? And how many more times do we operate on her? So all of this was taken into action. And I think we thought of retaining the plate, removing these 3 distal screws, holding on to the plate, and then trying to go ahead. So this was the pre-op checklist. I think most importantly is the position of the knee, which we had to keep in mind because we need to get the distal femur cut first. We also planned for having the extra unicortical locking screws, 14 to 20 mm in size, so that we can fill up the empty holes later if need be, if there's going to be instability. So this was the plan. So we went in, and the other pre-op planning, which I had also had in mind, was to put a distal femur longer stem along with the TKR, sir. But while measuring this, excuse me. So while measuring from here, this lady was actually a tall lady, sir. So she almost had the length was about 16, almost 160 mm over here. So the only option, even when we are going to put a retrograde nail, the starting size for AP locking starts only at 240. Otherwise, whatever implant you're going to use is going to be only lateral locking, and then the plate needs to be taken off if that needs to be the case. So we had positioned it, removed the screws, seen what the length was. This was the distalmost aspect of the proximal screws, which was around 320 mm over there. And then we had reduced the fracture via the lateral approach once the screws were removed. We passed the intramedullary guide, took the distal femur cut initially, proceeded with passing the guide wire, measuring and inserting the nail up till the tip level. Once we took off the screws, got adequate reduction without needing to open anteriorly, and completed the case by using a femur size 4, a tibia size 3, along with the stem on the tibial side as well. And we had done a 340 mm retrograde femur nailing as well, sir. And this was the X-ray, which was there post-operatively. The patient wasn't made to weight bear initially for the first 2 weeks. Once the wound, everything got settled, we started on our own from the first day. And once she was kind of active and she felt confident, she was made to weight bear. And this was at 2 months. We can see some amount of fracture gap, which is appearing, and some amount of oligotrophic union which is occurring over there, sir. And this is at 6 months now. But as of now, the patient is compliant, able to walk, do her day-to-day activities better than what she did before. And we are just waiting and not planned for anything as of now. One of the options at 2-month follow-up was to take off the screw, but then they weren't too keen on it, and they asked whether they can just wait. And following that, had gone through a lot of literature search, and a few points which as Vijay Bose sir has said, was for Vancouver type Cs, you have to be very, very careful. Always look for a long union time. Put the longest spanning plate as possible. Try to get fracture stability. Further, a comparative outcome of peri-implant periprosthetic fracture, almost 130 cases had told that there's almost a mortality rate of 23% within the first 2 years in these patients. And also atypical fractures presentation with alendronate is also kind of high, because this patient initially was started on it as well, and then was started to terifract. But I don't think that is the leading cause in this. But the one thing is, a female periprosthetic fracture beyond 65, a lot of things to look out. And I wanted to know, also on reading literature, the fracture rates at 2030, it's almost going to increase by said. So even the article.
65 boneless.
Can you go back to the last X-ray?
Yes, sir.
What is this?
Tarun, what is the rationale of using a separate nail instead of using it on the femoral component?
So while checking for length, it was longer, sir. So I thought the stability cannot be achieved in that, sir. At least what was available when I had requested when I had requested to both the company personals and trying to speak with a lot of them, they said that the available length along with the distal femur implant in itself is going to be difficult. So a shorter stem, as in the stubbier ones, are the ones which go longer. But in this case, that wasn't filling the stems. So that was the rationale. To get stability at the fracture site was also something which was keen, sir. At least the
CR femur or a PS femur?
So this is a CR femur, sir.
CR femur. Okay. Okay.
So
you
what are you waiting for now?
for
the implant?
Yeah, actually, I wanted to ask that as well, sir. Is there a femur with this length, sir? As in the distal femur implant in itself, the stem itself?
This is not very high. It's not very high at all. So any.
What is the distance?
Sir?
What is the distance? I mean, what is the distance from the joint to the fracture?
The distance was, sir, the distance was 340, sir. To the fracture, sir, 160.
From the joint
Smith & Nephew has 220 now, sir. Smith & Nephew has 220, I think. 220.
Yes, sir. They had 220, correct, sir. They had a 220.
Smith & Nephew 220, and then next stem is there. Bout stems, both are.
Okay.
Yeah,
okay,
all implants will bypass this, will have stems to bypass this particular fracture. It's not very high.
Okay.
But tell me, Tarun, what is the difference between what you have done and with a stemmed femoral component? What is the difference between the two? What are you waiting for now? Waiting for the thing to fail.
But I think on the face of it looks nice when you first showed me the X-ray, the immediate post-op. But now the follow-up one, the way the fracture is looking, something is worrying me about it. I can't. Because the ends are beginning to look a little sclerotic, as if the gap is looking a little bit more well-defined, even though there is a little bit of extra bone forming.
Sorry for the poor X-rays, sir. Definitely, it looks better in comparison to 2 months. 2 months look more scarier, sir. Slightly better, and she is also more active now. I couldn't call her up for follow-up because she had to travel from far. So I'll definitely follow up on this. And
no, what is the difference between biomechanically between stemmed femoral component and what you have done?
So because in stemmed femoral component, you'll get rotational stability at the site of the knee. So
no.
Now
Here you will get rotational, because here you are locked it, you'll get stability. there you
Yes,
won't get stability because you're not going to lock it, isn't it?
Oh, okay, yes.
So is this
Yeah.
superior to the other one you're saying?
Yeah, I mean, I think what he's done is that he's basically dissociated the two problems. The osteoarthritis is treated with a knee replacement, and the fracture is treated with an intramedullary rod. So
Yeah.
No,
the
we
two
understand that, but is there any advantage of doing the stemmed femur over this? That's the question.
now either can
Sir,
fail.
the only reason why I didn't do a stem femur was,
They don't fail
sorry.
together.
The load would get bypassed if you do a femoral
Yeah,
component.
you get a load bypass. Load bypass is critical. I
Okay.
would bet my last rupee that your fracture would have been well joined by now.
Okay, okay, sir.
Although, so I would have added a plate there, that's for sure, for rotation stability. But what you're
Okay.
really getting is the load bypass. Load bypass is the key.
Sure, sir. Sure, sir. Point taken, sir.
Sir,
The
other
load
thing
bypass-
is a tibial. The tibial stem is cemented or uncemented?
The issue was both with Smith and Nephew and with Depi. When I had contacted them, when we had done the pre-op planning, they said those implants weren't available. I think I should have reached out to y'all in order pre-operatively in itself to get more clarity on this. Otherwise, that was the plan, sir. What is the consensus now is the same plan which I had, but because there wasn't any other option and I didn't want to not operate on the knee, and that's the reason why I think this. Now, hopefully next time I'll do the load bypass.
But is this united, you think? 6 months is 24 weeks. So it's either, I mean, by definition, it's almost a non-union, isn't it?
But usually for femur, even the literature now for any distal femur fracture to coin it, it's at least 1 year, sir. For any distal femur right now. You should all the evidence, at least in the trauma, says that beyond 9 months is when we can even call that. And a lot of people are now putting them on non-weight bearing for about 4 to 6 months as well. And they do distal femur locking plates. With a lot of metaphyseal combination. I'm saying based on that, sir, not this transverse fracture, and definitely not.
If you don't want to operate on
something at this stage,
now.
I mean,
Sir?
dynamize and bone graft. I think it warrants it now. I think 6 months it looks quite like a communion. Yeah.
Sure,
I
sir.
would
Sure,
strongly
sir.
suggest that you intervene now before it fails. You
Okay,
put
sir.
bone graft, you put dynamicin, and you put a plate on it.
Yes, sir.
No,
You have to put a plate on it.
What will fail, Vijay? The fracture.
Yeah. He's going to non-union for sure.
And is there a route to get this nail out in case if you want to change it or if it breaks? It is going to be difficult to get this nail out with the CR component being there. I think that is another thing you would have to consider. Therefore, I think you should intervene earlier than let the nail break and it is
Tarun, you should intervene this.
to get it out.
Now,
Sure, sir. Sure, sir. So,
now as a
at
matter of
least
principle, we always put a plate, dual intramedullary and extramedullary implant we do. The other
Yes,
thing
sir.
is, since we do a large number of periprosthetic fractures,
Yes,
this
sir.
spanning, even when we do, a tumor process for, a comminuted distal femur, after some
Yes,
time
sir.
they break it above your stem.
Yeah, yeah.
Just the
you
process going on and on. So we are getting more and more radical in spanning the whole femur, even prophylactically. I mean, we see so many of repeat fractures. Periprosthetic
Okay.
fracture, you're done, fracture is healed, then the next successive fracture occurs.
Yeah.
Now the stress riser point is where the first fracture happened, is it?
No, second fracture.
The second fracture, the stress risers, the initial fractures here, sir.
Yeah.
So Tarun, strongly advise you to intervene now. Get it in. Then you have to throw all your cards in at this time, not wait for anything to happen.
Yeah, if she doesn't want another surgery, then at least BMAC.
Yeah.